So we've seen that this technology has been effective in the use as a preventive for autoimmunity and for cancer.
Well,
if that's correct.
Yep.
Okay.
The only autoimmune, I would say, the only autoimmune model that we looked at was the inflammatory colitis model.
Okay.
Yep.
Could, from your perspective, what are the chances of this therapy being effective for other inflammatory or autoimmune conditions?
Well, that's very easy to answer. I can't give you a rationale why it wouldn't work. So my prediction would be that it should be generally applicable to inflammatory diseases. It should be generally applicable to infectious diseases. It should be generally applicable to anything that has an immunological bias, because what we're doing is perturbing the immunological system. And if you accept that the immune system has an important role to play in malignancy, and all that you hear now about immunotherapy of cancer is predicated on that being accepted now. So we've accepted that. Then perturbing the immune system should be relevant in cancer. If you accept that the immune system is relevant in inflammation, and in fact it's immunological components that are contributing to inflammation, so it's a sine qua non that if you perturb the immune system, you're going to alter immunoregulation of inflammation. And obviously autoimmune disease, the nomenclature alone tells you that if you perturb the immune system, you're going to alter autoimmune disease. So yeah, I don't see that's an issue.
Excellent. Okay. And we've seen that it does work to prevent the the spread of cancer in the body. Also, we've seen in the data that it also has shrunk a transplanted tumor. So when we challenged the mice, healthy mice, with a transplanted tumor from another group of mice, that tumor shrank, we saw, to about a third of the size, if I'm correct. And also that it was a breast cancer tumor. It was transplanted onto the breast or the chest of the mice, and we also saw a much decreased rate of the spread of tumors or nodules to the lungs, which is usually the case with such a challenge. Would this? So we've seen effectively, if I'm correct, and correct me if I'm wrong, please, but that this treatment does prevent the development of cancer in a mammal. Is that correct?
In one model, a transplantable mouse breast cancer model, where we have shown that the tumor itself has the potential to elicit an immune response, then we've shown that this kind of immunoregulation can alter tumor growth at the primary site in the mammary fat pad and can alter metastasis to the local lymph nodes and to the lung and the liver. We have not documented that in any other malignancy model in mice. We haven't documented it in anything other than mice with a transplantable breast cancer. And there is one transplantable breast cancer, which is a very inflammatory breast cancer. Just that breast cancer in humans comes in multiple shapes and forms. And the model that we've used produces very little inflammatory infiltrate. But there is another model we have where there's a severe inflammatory infiltrate. And in actual fact, in that particular model, the immunoregulation we've looked at doesn't work, or at least if it works, it doesn't work fast enough to stop the tumor from growing. So this needs a lot more work before we would ever consider arguing that this is a therapy we can routinely apply for malignancy. But have we shown that it works in a malignancy model? Yes, unequivocally.
Excellent. And so is there reason to believe that this could work for the prevention or even treatment of other cancers?
It's not been. I can't answer that question because it's not been tested. I mean, the field of cancer therapy, immunotherapy, and all other therapies is rife with people who claim one thing, and then when put to the test, it proved ineffective. So the simple answer is we have not tested it. We've not tested it in a preventative situation. So I can't answer that question.
What has been the track record with this treatment when applied to allergy?
Well, the allergy model is very clear cut. I mean, we adopted a model that's very common in rodents, in small rodents. We adopted a model which I guess is the closest way to think of it is as a food allergy model. We give the animals something to drink that causes weight loss, diarrhea, and they do develop an allergic response to it. And the classical way we measure allergic responses is by looking at a particular antibody production, IgE antibody. So they develop an antibody response to that. I might say that some people use the same antigen, because we're using ovalbumin fed to the mice. Some people use the same antigen and actually insufflate it so the animals get to sneeze. So it can be used as a respiratory allergen as well. That's not the way we used it. But in every experiment we've done with the animals fed ovalbumin, they develop all of the pathology of an animal who's got a food allergy. So they lose weight, they look sick, they get diarrhea. We can stop that. We can stop that entirely with this treatment. And then the most exciting thing was that we could then continue to give them the allergen. So we continue to expose them to ovalbumin, but we stopped the treatment after 5 doses. And we asked, were they still protected from the ovalbumin allergic induction? And the answer was yes. They were still protected many, many weeks later. And so again, you have to remember the mice live for about 18 to 24 months, so 2 years. Humans live up to, let's say, 80 years. So there's a 40-year lifespan difference. So if you've protected mice for 6 to 8 weeks post the last therapy, that translates 40 times 6 to 8 weeks. That translates into nearly 240 to 250 weeks of extra protection, another 5 years. So one short course of therapy for 5 weeks, and they're protected for 5 years. That's a very profound effect. Now, that's a gross extrapolation. Some people might argue you can't do that. You can't just multiply everything by 40. I'm not saying it's a one-on-one correlation. I'm just saying that you have to remember it's not likely to be just 5 or 6 weeks in man, because the projected lifespan of mice is very different. So it was a very profound effect. I was intrigued, and I was very pleasantly surprised that the effect persisted for so long.
Okay, and so we've seen that we are using something other than the allergen itself as a therapy with this treatment, correct? Now, that's one difference. So it's the same therapy, if I'm correct, for all different allergies.
Yeah, you can remember what we're talking about here is immune perturbation, and as I gave you that example of a web spreading out, and I said when you get out to the 4th, 5th order, the perturbations out on the periphery are actually not even primary perturbations in response to this antigen. They're in response to other antigens, and that's what we're dealing with here. We're dealing with applying an antibody and an anti-idiotype antibody to one antigen, but the effect we're seeing is on an immune response to something quite different. So yeah, in principle, the allergen to which you're allergic is irrelevant in the context of the treatment we're using. One treatment sort of fits all.
Excellent. Okay, so it's a universal treatment for allergy.
Yeah, that's certainly the way it would look.
Is it better? And if so, why is it better than, say, something like a Claritin or other antihistamine-based treatment?
Well, the simple response is the answer I already gave you. I mean, I can stop the treatment after 5 weeks, and the mice are protected for at least another 6 weeks beyond that. I should say at least 6 weeks. We didn't go beyond six more weeks before we tested them. If you're going to use pills to treat your allergies, you're taking them every day. And as soon as you stop taking them, the symptoms are going to come back. So you take them every day for the rest of your life, if that's the route you want to go. I'm not knocking that route. Some people are quite happy to do that. But that's what you're locked into. You're going to be taking this medication daily.